Then I can carry, so.
I trust you.
Yeah, sure. Right, so let me go in, change. Have you prepared dinner for me?
Definitely.
Okay, so let me go change. So.
Okay, baby.
All right. So, baby.
You mean you're full already?
Yes.
I'll do some more.
No, you don't have to. Actually, I was hungry in the office, but coming home to eat from my wife's pot is the best.
Okay, Auntie.
Yes?
Please clear the table. Alafu, tusaidia maji kidogo.
So,
Nice.
This is delicious.
As always, you know, I don't joke when it's come to your tummy.
And that is one of the qualities why I'm married.
Oh.
Yes. Sante.
Hi.
Okay. So this is my own home. Don't mind. All right.
Well, something just crossed my mind. So, will me sit next to you? Since tomorrow is our anniversary, and we've been so busy lately, we haven't planned anything. Do you have any plans for us? I hope it's not Dubai this time.
It is not Dubai. And also I've made a reservation at a surprise restaurant for a full course dinner. Just for the two.
Wow, I love you so much.
Love you too, baby.
Okay, I think we go to bed.
Sure. Let's go to bed. Tomorrow is another day.
Sit down. Kalechi will be fine. Have faith.
Sweetheart, how do you expect me to sit when our boy is not okay? Nobody's saying anything to us. No results, no response, nothing. Yes.
Mr. and Mrs. Asante, I'm afraid the results are positive.
Positive.
Your son has tested positive for sickle disease.
Doctor, our child is a healthy child. Please, run around first.
We have done more than one test. I know it's not going to be easy, but we will start you on counseling. Don't worry, Mr. Asante. It is manageable. We will start him on treatment immediately. We'll put him on penicillin, a prophylaxis antibiotic, hydroxyurea, which prevents falling into crisis, folic acid, a blood booster, and Palodrin, a prophylaxis anti-malarial drug that will prevent him from getting malaria frequently. As for the pain, we'll give him a stronger painkiller to suppress it.
Doctor, isn't that too much drugs for a child?
Not really, Mrs. Asante. Every drug is important for the child, as without it, the child might fall into crisis that becomes terminal.
But I thought his father was AA. How then can he test positive?
We can only be sure of that if we do a gene test on him. But based on these results, it shows that he could be a carrier. He may have the sickle cell gene, which he in turn passed on to your son.
Not my son, doctor, not my son.
Sweetheart, you should be fine. I'll come for you. You go through this stuff, please.
Thank you for watching, and through this movie we have decided to write another script called Wiping Tears. That is a continuation of that, and it's an expansion of it. So we are asking for your support. Thank you very much. Yeah.
So another round of applause for Michelle and team. Indeed, I think that is among the things we were talking about in the morning, innovative ways to advance advocacy for sickle cell disease and hemophilia care. And Michelle and team, thank you so much for doing that. That is a good job. I hope we can all send something to support the team there. Okay, fine. So I would want to request us to quickly move into our specific rooms. I would want to start by calling out the chairs and the moderators to take up their positions. So for Victoria Hall, which is this hall, will be handling governance, policy, finance, and advocacy in sickle cell disease care. The chair for this session should be Dr. Fuller Caroline, and moderator is Sam Bunya. Kindly take your positions. The next, dealing with sickle cell disease and hemophilia in diverse clinical landscape, innovations in sickle cell disease management and hemophilia management. The chair is Dr. Eve Okello, moderator Alan Otieno. I don't know where, are you in the building? You should be going to Milambo, not Masawa. Yeah? Sure. The third hall, which is Yimbo, this is where we're going to present abstracts on comprehensive management of sickle cell disease and hemophilia. The chair for this session is Dr. Namulala Emma, moderator Dr. Matilda Ongondi. Dr. your hall is Yimbo. Kindly let's start moving for those ones who are moving. And then the fourth one, which will be held in Ugwe, this is where we are presenting on prevalence and management of sickle cell disease and hemophilia. The chair for this session will be Dr. Dickens Onyango, moderator Dr. Abdallah Mohammed. That is track number 4, the hall is Ugwe. I request we take less than 5 minutes, kindly 2 minutes to move. We do not have much time, and we're hoping to listen to all the abstracts that were submitted. Thank you.
Come with what? I'm supposed to come with my laptop.
With your laptop, then I connect you to the
In those breakouts.
So for clarification, the rest of the halls are down here. This is Victoria Hall. Ugwe, Milambo, and Imbo are downstairs. Some.
Here's the presentation. Here's the printer. So the breakaway is it one presentation of everybody? So
ready to just to do this one.
okay, in the breakaway is there projection? Okay, on the projection, who is supposed to write from laptop the modulator will come with the laptop. So tunaweza sema hii tunaweza sort so ikifika hapo chini wako sote because the projectors I have to I know equal job
Like this, of which is someone else's chair.
Where do you want? Where do you want? It's just a question. Where do you want? Let me do. Hey boss, good job. Wachilia. Good job. Nyangu, twende. Okay, so I need yes,
unajua tunaenda hivi acha ni
so
okay, we just want to take a few moments to catch our breaths. And if possible, could we come in front? Jenny mbele. Sitaki kuona watu nyuma. Please come forward. We need more engagement. Yeah, this is serious stuff here. We're talking about something. Karibuni. Please come forward. If you're still at work, I will bring you forward.
Lakini hatuna time.
We're supposed to be ending at 1.
afternoon. Good afternoon. Good afternoon. Good afternoon. Yeah, so welcome to this track. This is track 1. Your chair will be Dr. Caroline Hemophilia, moderated by Sam. We are going to look at the track that deals with policy and governance. So we will be having 5 panelists with us, then introducing themselves. And as we go on, questions, kindly write them down. And as you write them down, at the end of it all, we will have a question and answer session. So for this time, allow me to welcome, are you ready? Yeah, our first presenter to come to be outstanding. Let's give it up for our first presenter. Yeah, this is William Veronica Bita. Veronica Bita, you're our first presenter. William Otuga is not here. Professor Muga is equally not here. Debbie. So as Dr. comes on board, as I said, I'm Dr. Caroline Hemophilia. I'm a clinical pharmacist, trained from the University of Nairobi, with a bias to pediatrics and oncology. So Dr. Debbie, feel welcome as you take us through this session. Thank you.
Good morning, everybody. My name is Dr. Deborah Mredo. Alright, thank you. So I am a pediatric hematologist and oncologist. I work in KC Teaching and Referral Hospital, and I'm going to share some of the things I think are useful in taking care of anyone living with sickle cell. So as we have been told in the previous sessions, about 112 children per 100,000 are born with sickle cell all over the world. However, in Africa, we have 1,125 in every 100,000 children born with sickle cell. So we carry one of the largest burdens of sickle cell all over the world, and so it has to be a health priority in our country. So in Kenya, from the few studies done, it is said that 4.5% of children are born with sickle cell. And this is likely to be an underestimate because many health facilities don't even have the testing facilities. So it's possible that these numbers are much more than we are being told in the literature. So what we need to do, we need to make sure that there's universal neonatal screening and infant screening, and we are happy that there's a policy on that, and that anybody, and that every county referral hospital can have even the high performance liquid chromatography testing, which is slightly better than the HbA electrophoresis, so that we can even capture the other hemoglobinopathies apart from sickle cell. There could be other things like thalassemia and all those other things, other hemoglobinopathies. But at least if the HbA1c is not possible, then at least the HbA electrophoresis should be available in every county referral hospital. And then we should make sure that rapid test kits and the training of staff to make sure that they are used very well are available in every health facility. Would like the testing of sickle cell to be like the testing of HIV, such that anyone who wants to know their status, whether they have money in their pocket or not, can get tested, know their status, and if they have this disease, they are immediately recruited into a clinic wherever they are and given a good treatment and the drugs, whether they have the money or not. Then, if a facility doesn't have a HbA electrophoresis machine or the rapid test kits, we should not say that, oh, the situation is hopeless, there's no need. We can still utilize the available Sickle tests and peripheral blood films in every case of anemia and suspected sickle cell disease. And that way we can still capture a few as we hope they continue advocating and making sure that every health facility has got the confirmatory tests available. So, diagnosis. After you have discovered that this person has sickle cell, what do you do next? Number one, we need to give this patient penicillin V. Penicillin V is an antibiotic that one should take daily, twice in a day, to prevent bacterial infections. So the dose for children less than 3 years is 125 milligrams 12 hourly. For those who are more than 3 years and into adulthood, it's 250 milligrams 12 hourly. Some people think that you can stop when you're 5 years old, but the thing is that the reason we give penicillin V is that the spleen of anyone living with sickle cell is not working very well in the fight of diseases. And so when you reach 5 years old, the spleen is still not working very well. And so it's important to be able to have the antibiotic in the system so that whenever any bacterial infection can come, there's some level of protection. We know that we have vaccines, but we do not have vaccines for all bacterial infections. Common infections like staphylococcal infections, we don't even have a vaccine for that, and yet it can cause pus and boils and skin infections. So having penicillin V in the system is very, very important. Secondly, we give folic acid. We know as the cells break down, and we know people living with sickle cell, their cells break down a lot quicker than the people who do not have sickle cell. Folic acid is lost in urine. And so we usually, for the neonates, we can give 5 milligrams once a week. For the infants above a month old, we can give 2.5 milligrams once a week. And for anyone above 1 year, 5 milligrams once a day is enough. Then the third drug is proguanil. Proguanil serves two roles. Number one, it prevents malaria. And secondly, it also prevents a complication of sickle cell called hypersplenism. Hypersplenism is when the spleen becomes so big, so big that it traps all the blood cells, the red cells, the white cells, and the platelets, and can cause very many complications. So we found that countries where proguanil is given routinely to people living with sickle cell, you find the cases of hypersplenism are much lower than countries that maybe use Fansida or other, or no prophylaxis at all. So proguanil is important, and those are the dosages for the various ages and weight categories. So one of the most important drugs is hydroxyurea. This is the only drug that changes the shape of the cell of people living with sickle cell. It does a lot of important things. It increases HbF. We know all of us, when we're in our mother's stomachs, we have HbF as the main hemoglobin type. But as we approach 2 months of age, 3 months of age, the F goes down, and then your predominant adult hemoglobin becomes predominant, the A